So today I'm going to speak about empathy and dementia. It's a theme I came across during the past year. I haven't done my own research otherwise than reviewing it, but it's a very interesting topic, I think, in old age psychiatry as well. Just a second. So a few words for the introduction. We know people worldwide are actually living longer, and according to WHO, the projections show that by 2030, 1 in 6 people will actually be aged 60 years or over. And we know that by 2020, the world's population of people aged 60 years or more might even double. So we know the cognitive and psychological challenges in old age can be really tough. Older adults in lowest income have 60% higher rates of depression than the counterparts with higher income. They're less educated as a group, and they have many chronic conditions. People above 80 years have actually more than 2 or more chronic conditions. So empathy, or the ability that we can imagine what someone else might be feeling or thinking, is actually a crucial component of meaningful care provision and therapy, and including, of course, also person-centered care. And it has actually been shown that to enhance care provider and patient well-being, empathy seems really important. So I know you've heard a lot about dementia. Today, we know the increases in population growth and population ages will actually bring huge increases in the number of people with dementia. By 2050, the numbers might triple. And of course, the multimodal interventions have shown some success in delaying the rate of cognitive decline. And to develop effective therapeutic strategies, it's really important in the post-diagnostic care to encourage good communication also in therapy with our patients. And empathy is a really important element that can influence communication. So empathy is actually a really complex concept that has long been debated by philosophers and social psychologists, and it can lead to a multitude of different conditions with also negative impacts on research and clinical practice. And we can conceptualize empathy as the ability to both feel and also understand what others feel. And it has at least 2 distinct components: an affective or emotional one, including creating an emotional response in the observer, understanding that I feel what you feel, and also a cognitive component, which include understanding and recognizing another's emotional state, meaning that I can understand how you might be feeling. So the cognitive component incorporates complex cognitive functions, which I'm going to talk a little bit about later, including perspective taking and mentalizing, while the affective component contains more experience sharing of an individual internal feelings or states. So empathy, both as a concept and also as a psychological process, is related also to the theory of mind and emotional contagion. We know that emotional contagion is actually the unintentional mimicry and subsequent synchronization of another's effect or emotion, and is more considered of a primitive component of empathy. On the other hand, theory of mind is the ability to attribute mental states, our beliefs and intents and desires and emotions to oneself and other, and to understand that others might have mental states and emotions that can be distinct from our own. So like empathy, theory of mind can be separated actually into components: an affective one and a cognitive one. An affective theory of mind component involves drawing inferences about individuals' emotions and feelings, while the cognitive one more about their beliefs and intentions. So in contrast with empathy, theory of mind implies that cognitive and affective mental states are actually understood by us as observers, but not shared. So to start with my theme, it's very interesting that there has been a lot of research done on empathy in certain psychiatric disorders such as schizophrenia and autism spectrum disorders and mood disorders, but there are much less studies done in neurocognitive disorders regarding empathy. And my presentation actually summarizes some of the evidence regarding changes in the cognitive and affective domains and empathy in the most important forms of or types of dementia, and the impact of empathy also in therapeutic relationships. So regarding pathophysiology of empathy, there has a lot of studies have been done, and it's thought that actually the affective arousal occurs first, during which the amygdala and the hypothalamus and orbitofrontal cortex rapidly, automatically process the emotional signals that are received from the others who share their emotions. And emotion understanding, where we recognize that someone else is initiating the emotional experience, follows and evolves the medial and ventromedial prefrontal cortex, or so is thought, and temporoparietal junction. And the understanding of emotion requires mentalization ability. There are, of course, also other structures involved, but there have been actually 3 separate meta-analyses of brain activation that describe a core neural network of empathy that includes the anterior cingulum, the median cingulum, and the anterior insula. And there are other structures that might be as important that I'm going to talk about a little bit later. So brain networks involved in empathy can be also divided to emotional and cognitive components. And studies show that they recruit largely distinct brain networks in adults. So the studies examining the neural basis of empathy have used methods such as neuroimaging and other studies, and also patients with brain damage. But the key brain regions thought to be involved in emotional empathy include the anterior cingulate cortex and insula, ventromedial prefrontal cortex, and amygdala, while with cognitive empathy, the medial prefrontal cortex, temporal pole, posterior temporal sulcus, and hippocampus. Although they're not limited, or some of the studies have sort of contrary results. So the brain networks involved in empathy, in addition to this core network for empathy, there is evidence for at least 2 pathways that arrive at the core. There have been studies done also with pictures of body parts in painful situations, which are very interesting. And regarding empathy in neurocognitive disorders, the clinical understanding has recently improved quite a little bit, with the better understanding the role of empathy also in neurocognitive disorders. And the loss is especially important in some of the conditions. Most of the studies have been done on Alzheimer's disease. There's considerably less done in Lewy body dementia and vascular dementia, but more with frontotemporal dementia. I think the most of the studies come from frontotemporal dementia for the obvious reasons, and also with Parkinson's disease dementia. So Alzheimer's disease, we know, is the most common form of dementia, most prevalent in people above 65 years of age. We have accumulation of amyloid plaques in neurons and a widespread loss of gray matter and progressive cognitive decline following. We have episodic memory that is impaired due to degeneration. And brain imaging predominantly shows gray matter atrophy and decreased metabolic activity in posterior cingulum and also other places. And in patients with Alzheimer's disease, studies actually report affective component of empathy as preserved, while the cognitive component impaired, which seems quite logical. And the studies involve, some of the studies actually involve functional neuroimaging, and the other ones scales. And it's really interesting that it relates to self-rated and caregiver-rated results. And the visual recognition of emotional facial expressions, a process that is necessary in effective mentalizing, is generally relatively preserved in Alzheimer's disease patients, except of fearful and ambiguous expressions, which is interesting. And on fMRI, there was a left lateralized decrease in neuronal activity in patients with Alzheimer's disease that is, of course, in correlation with atrophy or neurodegeneration itself, with the location. And the overall scores for empathy in Alzheimer's disease patients were actually significantly higher than in patients with behavioral variant of frontotemporal dementia, which we can, of course, expect. How about empathy in frontotemporal dementia? Frontotemporal dementia is, of course, a group of heterogeneous dementias. We have loss of behavior control in behavioral variant and loss of language abilities in semantic dementia or progressive non-fluent aphasia and so on with verbal types. And that is, of course, associated with general degeneration in frontal and anterior temporal lobes. And we have specific degeneration in paralimbic brain areas. And in behavioral variant of frontotemporal dementia, typical core symptoms are behavioral egocentrism and actually quite considerable interpersonal difficulties, which are, of course, reflected also by disrupted empathy and emotion. Okay. So most studies that report empathy in frontotemporal dementia report both cognitive and affective components as lower. Of course, that depends on the stage of dementia as well, but affective empathy is assessed in patients with behavioral variant frontotemporal dementia through different mechanisms, different study mechanisms. And it was interesting when they looked at the EMG reactivity for facial muscles implicated in negative emotional reactions like frowning. It was not very different from controls, but in positive emotions, they actually, the results were irrespective of the presented facial emotion expressions. And the patients with behavioral variant frontotemporal dementia scored low on visual and verbal tasks, especially where they showed vignette of social situations and measured affective components. There were more prominent deficits in affective mentalizing, and they couldn't discriminate violations of social norms and more aggressive images. And in tasks that presented faces with emotional expressions, patients with behavioral variant frontotemporal dementia consistently showed impaired, selecting the appropriate emotional category, like in the picture, of the presented face was mostly impaired. And empathy for pain, the patients that were rated as lower levels of intentionality compared to healthy controls, and they were less aroused by negative valence images, while neutral and positive was as arousing as controls. But in contrast, in the language variant, in the language manifestation of frontotemporal dementia, there was a few studies done with semantic dementia patients. There were no differences or no inconsistencies showed in empathy. So the core deficit in behavioral variant is both affective and cognitive empathy, and they can especially not discriminate between harmful and not harmful intentions and lack the capacity to respond with the appropriate facial expression to the emotions of other people, and they cannot even correctly identify the perceived emotion, and that makes it that much difficult to anticipate people's behavior in social context. So, of course, the insight is a problem. They're unaware of the deficits, and in semantic dementia, the knowledge is so far less thorough. And there was one study with patients with PNFA, and there were no actually important differences. So how about patients in Parkinson's disease dementia? We know the known motor symptoms in Parkinson's disease also involve cognitive deficits and deficits in executive functioning, memory, and also neuropsychiatric symptoms. And dementia can be middle stage or late stage complication or neutral or a normal course of disease in Parkinson's disease as well. And neuroimaging can show us a widespread gray matter atrophy, even in people with Parkinson's disease with no dementia. And in fMRI studies, there were significant perfusion decrements that were actually limited more to the frontal lobe area. And with those with dementia, of course, the gray matter atrophy spreads also to the subcortical structures. And it was interesting, at least for me, that the patients presented deficits of both affective and cognitive empathy with brain atrophy and hypoperfusion. And there were importantly lowered results even on facial emotion recognition. So the areas important for both affective and cognitive empathy are impaired in Parkinson's disease dementia. Yeah, so there's a lot less knowledge on other types of dementia, but empathy, I looked to another poll as well, and empathy is actually really important in doctor-patient relationship as well, but there are, interestingly, no publications investigating the influence on patient of the patient's empathy in doctor-patient relationship. There's, of course, a broad spectrum of empathy alteration in mental disease in old age as well, not just neurodegenerative disorders that actually may influence the clinical relationships, and more knowledge could enable at least more tailored strategies. So empathy is tightly related also to ageism. There's a lot of studies being done in that field. And the more we know of the aging process, the more positive attitudes towards aging can be actually, can we have in our clinical work as well. But I don't think it's a problem in this setting because we're both actually treating old age, but it can be a problem in this medicine as well. So we know older people with mental health conditions are often confronted with even double discrimination by both age and mental health conditions. And it's also a question of empathy, I believe. That slide I'm just showing out of interest. I don't know if you've seen the debate. It's been really amusing. I think 2 years back, there's been a lot of public campaign and public debate going on with the inclusion of old age as a supplement in ICD-11. And there was actually quite a few published opinions. That one was also interesting. It was published, I think 6 months back or 8 months back, how old age was actually withdrawn as a diagnosis. And it was a huge criticism on aging. Of course, there was also a COVID-19 pandemic that actually shed a light on ageist attitudes as well. And it was also interesting that there are a lot of studies when they are showing what are the most effective interventions to improve empathy and ageist attitudes. And there are systematic reviews and meta-analysis. And they designed interventions to improve positive attitudes and enhance empathy, and found out that actually interventions are most effective, that those interventions that are based on enhancing empathy have the greatest impact and are most effective. And they were done by simulations mostly with medical staff, and if they personally perceived the physical limitations associated with aging following these experiences, they were able to verbalize feelings of defenselessness and resignation, and that actually could help with enhancing empathy. So to conclude, so that I don't run out of time, empathy can, of course, be broadly defined as the ability to understand and feel what others feel. And the neural networks underlying empathy are being explored currently. There are several structures involved to be key. And the patients with Alzheimer's disease seem to exhibit some deficits in empathy, but to a much lesser extent than patients with other types of dementia, especially the frontotemporal dementia, the behavioral type, as we saw. And these deficits involve predominantly cognitive empathy as a result of, in Alzheimer's disease, as a result of overall cognitive decline, rather than targeted empathy loss. But however, empathy is markedly impaired in frontotemporal disease patients, and it may relate to also, as a consequence, a loss of a caring carer, and it may really largely influence the patient relationship and increase the caregiver burden. And of course, future research might add to knowledge. I think the studies are really interesting, and more can be done probably on dementia with Lewy body and vascular dementia and Parkinson's disease dementia. And of course, with mental health conditions may benefit also from self-reflection from time to time to increase awareness of ageist attitudes and also empathy. So I think addressing ageism is from time to time also vital in achieving optimal treatment outcomes and attitudes. Thank you.